All right, everyone. Um, since it's almost 9 o'clock and I don't have anyone in class, I guess everybody is done with the semester and not planning on coming. So I'm just going to do a very brief overview of the case studies. I was going to give extra credit for those that presented, but I can't do that if nobody's here. So for the COPD case study, I have selected Mary's to review, and her situation was the patient was working in, or she was working in the ED of a large academic hospital in upstate New York as a respiratory therapist. Charlie is a 65-year-old male patient who asked his youngest daughter, who lives very close to him, to take him to the hospital for evaluation. His chief complaint is shortness of breath with a productive cough in the morning that progresses to a non-productive cough. He reports that he has been experiencing increased trouble breathing. He describes it as a difficulty on expiration at rest and with worsening on exertion. He also states he has had a productive cough. Upon examination, he is conscious, alert, and oriented ×3 with a slight fever of 37.9 degrees Celsius. Heart rate 100 beats, respiratory rate 24, as she appropriately stated to Kipnick. BP 140/80, hypertensive. Wheezing auscultated in all lung fields superimposed over a long expiratory cycle. What medication would you give him at this time? The correct answer is albuterol and ipratropium. Remember that when you have albuterol and ipratropium, which is a anticholinergic, they act synergistically together and help the bronchodilation last longer. How would you assess the efficacy of your treatment? As with every time you're giving a breathing treatment, you're going to auscultate the lungs before and after and take vital signs. However, the big thing here, in order to be able to evaluate quantifiably that you have made a difference or that they have a response to the bronchodilator, you would do the peak flow pre and post. Then you would know if you actually have made a difference in the flow restriction that they have. Observing the work of breathing and their SATs, all fantastic answers to be able to determine the efficacy of your treatment. His past medical history includes COPD, current medications, Combivent, Advair, albuterol. When asked, the patient says he doesn't know what these medications are or why he takes them. You will find that that does happen, especially with the elderly. They just do what they're told and don't really think about the whys. So she said that she would explain that the Combivent should be taken 2 times a day, or BID. It's also known as ipratropium bromide and albuterol. It's a combination of an anticholinergic and a selective beta-2 adrenergic medication. Now, when I talk to the patients, it's really hard for us to make that transition from respiratory lingo and respiratory school lingo, and when you're talking to the doctors, and then when you flip that switch and you're talking to the patients. But you usually have to, when you're talking to the patients, talk to them like you would a family member. They don't know what a selective beta-2 adrenergic is or an anticholinergic. So frequently when I talk to them, it is much more simply put. And I would just say that they are both bronchodilators that act in 2 different ways, that one of them relaxes the airway muscles, and the other medication actually blocks your body's normal response to reconstrict or re-narrow it, so it helps the bronchodilator last even longer. She stated anticholinergic bronchodilators are also known as muscarinic receptor antagonists that block the nerve reflexes that cause the airways to constrict in order to allow the air passages to remain open. Very good technical answer. Patient may not understand it, so keep that in mind. The Advair Diskus should be taken 2 times per day. This medication provides 500 mcg micrograms of fluticasone and 50 micrograms of salmeterol oral inhaler. This is a combination of a corticosteroid and a beta-2 adrenergic bronchodilator. The steroid is used to treat inflammation in the lungs, and salmeterol affects the smooth muscle, which causes dilation of the bronchial passages, providing more room in the bronchioles. Again, fantastic technical answer. The Advair Diskus, if I was explaining it to the patient, would be much more that Advair Diskus has both a bronchodilator in it and a steroid. The bronchodilator helps open up your airways, and the steroid helps calm down your inflammation and any irritation that is in your airways to help your lung function or to help you breathe better. And then albuterol MDI is prescribed 2 puffs PRN, meaning as needed. It's a meter dose inhaler, which is a bronchodilator that relaxes the muscles of the airway and increases airflow to the lungs. It delivers 90 micrograms albuterol per puff. All these medications are used to treat symptoms of COPD. Excellent answers, and she gave her sources for each one. The daughter feels that he may not be taking them correctly and asked you to explain the correct way to administer them and when. She gave a great description for each one of them. The Combivent Respimat is a soft meter inhaler. So you do not use a spacer with that because it aerosolizes the medication directly into the air. So point your inhaler towards the back of your throat while taking a slow, deep breath through your mouth. Press the dose release button and continue to breathe slowly for as long as you can. Hold your breath for 10 seconds or for as long as comfortable. Very nice explanation. Remember that the breathing slow and deep is the best way to get the best deposition so that more of it lands in your lungs and not in your upper airways. If you're breathing faster, you're going to have more turbulent flow. It's going to end up in the upper airways. With any of these medications, please make sure he is rinsing and spitting after use. Great advice. Then, upon further examination, it is discovered that he has thrush. Which medication is most likely the cause? Absolutely, Advair. What would you suggest to help alleviate this problem? I would confirm that the patient is using minimal dosing. Perfect. I would suggest that after ingesting his medications that he should rinse his mouth out with water, make sure to spit out the water after rinsing, and I would also advise that he rinses dentures if he has them as well. Very good point. Educate the patient regarding the use of a spacer and a reservoir device. Fantastic job, Mary. Thanks. So excellent job on the COPD. I would bring a couple of points up to you guys just to help get your understanding of COPD solidified here. When he talks about chief complaint is shortness of breath with a productive cough in the morning, very, very classic with COPDers, especially ones that smoke. So when they are smokers, one of the side effects of smoking is that the smoke paralyzes your cilia and it does not move very well. It doesn't move the mucus very well. So while they're sleeping and they're not smoking, the cilia will slowly start to be able to move again. So when they wake up, that mucus has moved and they are able to cough it up. And then as they start smoking, that cilia gets paralyzed again and they don't smoke, or they don't bring as much mucus up. So their cough is usually less productive during the day. So little tidbit of information for you. He described as having difficulty on expiration at rest with worsening exertion. When you listen to him, wheezing auscultated in all fields, superimposed over a long expiratory cycle. Long expiratory cycle would be another clue to you that he has COPD, and not only does he have COPD, but he definitely has a component of air trapping because the long expiratory cycle is them having excessive residual air in the lungs that they are trying to get rid of. We covered that. Did I give you anything else? That hypertensive, I would say that he is more hypertensive because he is having a hard time breathing, but additionally, if he is hypertensive and a COPDer with chronic bronchitis, he would fall into that category of a blue bloater. For the cyanosis, for the dyspnea on exertion, so they are not in good shape, and they also have that component of air trapping. Everything else I think we've pretty much covered here. So I'm going to move on to the next one, the asthma case. So the asthma case, part of the reason I was going to give extra credit for you guys presenting here is because the asthma case was one of the more challenging because it really made you get into the assessment of your patient. So, asthma patient, you are working in the hospital today and the doctor asked you to evaluate a 29-year-old male patient with shortness of breath and a history of asthma. He just moved into town a few months ago and has not seen a doctor, nor has any asthma action plan that he is aware of. The patient states that he has been more short of breath than usual. He states he used his albuterol MDI about 10 times yesterday. Typically, he uses it morning, noon, and evening. The shortness of breath began following a day of moving into his new apartment. What questions would you ask now? What more would you wish to know? So, for this asthma, your Bible, so to speak, is going to be the National Asthma Education Guidelines, the NAPP, which you have in your module. What questions would you ask now? What more would you wish to know? You are trying to place him, you are trying to assess him so that you can place him in a step. What symptoms are included in his what symptoms are included in his exacerbations is the question that Valeria was asking. So looking for, are you wheezing? Are you coughing? Are you short of breath? Are you bringing up any sputum? I'm assuming those are all the symptoms that she's looking for. Does it get better or worse at night? Have him do an FEV. Excellent on the FEV. The National Asthma Education Prevention Program. Let's see if I can pull this up for you. All right, pulling this up. For the asthma education guideline, this guideline is chock full of information. So first of all, on page 2, it gives you key clinical activities and action steps. So asthma diagnosis, in order to establish the asthma diagnosis in all patients greater than 5 years of age, use spirometry to determine that airway obstruction is at least partially reversible. So then if you're going into assessment and monitoring on this initial visit, assess the asthma severity to initiate treatment. And then it says see page 5. Well, hello, Jessica.
Hello.
How are you?
Good morning. I'm good.
You are actually now the only one here.
Oh, really? I'm the only one?
You are.
Late.
So if I was going to make the offer for the people that were here to do their presentations and get extra credit for it. So if you want to talk about your assignment.
Oh, okay, so I'm the only one here.
You are.
Okay. I wonder what happened to the
I know it. I think that they are just so totally done with the semester and saw that they passed, and I think they just gave up. If I had to make a guess.
I see.
All right, so let's see.
And did you say it was extra credit?
Yeah, I was just going to give a couple of extra points for presenting your case.
Oh, I see.
Would you like to do that or no?
I mean, I don't mind. But do you have to wait for someone else? You think maybe someone else would? I mean, maybe just forgot and maybe they'll get into the conference meeting. Do you think we should wait for someone else or no?
Well, we're already half an hour into the class,
Okay.
so we've only got 15 more minutes before the class ends. So or if you don't want to worry about it, then I will just go ahead and continue where I was. I was just presenting to nobody and recording it.
Oh, I see. Okay, I get you. Okay, so but I could do my presentation, but I don't have. Is this my paper or is it yours?
No, this is mine here. So if
Uh-huh.
you would like,
Okay.
I will continue on with the asthma presentation that I was doing,
Okay.
and then
Yeah.
we could just go back to yours and have you present that. Sound
Okay.
good?
Yes.
Okay, so I was in the middle of the asthma case study, and I was talking about this National Asthma Education and Prevention Program, the NAEPP. And on page 2, it gives you information as to how to assess a patient on their initial visit. So on the initial visit, you're going to assess at each visit the asthma control, proper medication technique, written asthma action plan, patient adherence, and patient concerns. So, and then it says determine if the therapy should be adjusted, maintain treatment, step up if needed, or step down if possible. Then going to the page 5, this is where you're going to determine what questions to ask for an asthmatic. So you want to know specifics of the symptoms. Are they less than 2 days a week, greater than 2 days a week, but not daily? Are they daily or are they throughout the day? Nighttime awakenings, are they none? Are they only 1 to 2 times a month? Are they 3 to 4 times a month? Are they greater than once a week but not nightly, etc.? And then how frequently are they using their SABAs? Are there exacerbations or are there trouble breathing interfering with their normal activity? What is their lung function? What is their FEV1? So in order to determine where they land in those steps, you need to get that. And then you've got more of the risk factor. So how many times have you had an asthma exacerbation that required going on oral systemic steroids? Based on the answers to all those, it would be the step that you would place them in. So going back to this case, what questions would you ask now? What more do you wish to know? That's what you wish to know, all of those. Then please answer the above questions, your choice as to how he responds to them. Which step would you place him in the NAEPP guidelines? So what I was hoping for was to get specific answers to these questions, which she did many of them. She gave what his symptoms were, didn't say how frequently, but he has been getting bad nighttime coughing. Again, didn't say how frequently, but from the information he gave me, I would put him on step 3. So the one definitive thing that she did get was his FEV1 was 70. So if you go back here, FEV1 of 70 would place him right here.
60 to 80%.
Yep. Now, he did say in this here that he states that he uses his albuterol about 10 times yesterday, and typically he uses it morning, afternoon, and evening. the shortness of breath began following a day of his moving to the new apartment. So if you look at him typically using his MDI morning, afternoon, and evening, you're looking at it being daily. Does that make sense?
Yeah.
Again, confirming that you are in this step 3 phase here. So,
Step 3.
I'm sorry?
Did you say step
Yeah,
3?
see, do you see it here? Step 3?
Yeah. Yeah.
So then, which medications would you recommend? Include dosage, administration route, and frequency of administration. Is there any other advice that you would give him? So, on this, it tells you step 3, you want to do a medium dose ICS. What does that stand for, Jessica?
ICS inhalation. Oh, the
Yeah.
ICS it stands for inhalation.
Inhaled corticosteroids.
Corticosteroids.
So it's ICS is
Okay.
your inhaled steroids.
Yeah.
So
it's inhaled corticosteroids.
yeah.
Okay.
So then if you continue on, not to this page, but this would be in this case study. There's a section that we go to the follow-up visits, but even more clearly what stepwise approach for managing asthma. On page 7, step 3, medium dose ICS. If it has an alternative treatment, it would be here. And then quick relief medication. Yes, he should continue his SABA, for instance, for symptoms, breakthrough symptoms or intensity of treatment. You can do the SABA every 4 to 6 hours for up to 24 hours. It says you could consider a short course of oral systemic steroids if the asthma exacerbation is severe or if the patient has a history of severe exacerbations. And then caution, frequent use of SABA may indicate the need to step up treatment. So back to, and then if you continue on, this asthma care quick reference really gives you everything that you could possibly want. It's saying, okay, what medication would you like to give them? And here is what the low dose, the medium dose, or the high dose would be of those individual medications. So then it would give you the beclomethasone or the budesonide or the budesonide nebs, all of that. It continues here. So you've got your choices. It then tells you even further therapeutic issues pertaining to these steroids. The most important determinant of appropriate dosing is the clinical judgment. It gives you all of this information, which is good. So going back here, I would have him take a steroid. Yes, she decided on budesonide. Now, she said 180 to 360 micrograms BID. You gotta pick. That's the range that it's in, but you should be going through and identifying, okay, based on the severity, would it be a medium dose, a low dose, a high dose? So then if you're saying step 3, and you go back to this step 3, this is 0 to 4 years, so it's not here. We're going to be going down here. Do you understand me where I'm going?
Yeah.
So
Yeah.
for this patient, it would be a low dose ICS and a LABA or medium dose ICS. Make sense?
Yes.
So since she opted just for the inhaled steroid, I would be doing the medium dose. Make sense?
Yes.
So she picked, what was it? Budesonide. So you're
Yes.
going to go
That's
to the
nice.
budesonide and you're going to look for medium dose
Which is 2 to 3 inhales twice daily.
of the 180. Do you see that here?
At the
Yeah.
180. Yeah. Yeah. At the 180.
So what she did was calculate this out, which is good because it's 2 to 3 inhalations twice daily. So 2 inhalations would be 180 times 2. Does that make sense?
Yeah. Yeah. Times 2.
So that would be the 360. If she upped it to 3, she would then have to add another 180 to that. So you would be the one determining what the dose would be. So if you say, because you wouldn't tell the patient that I want you to take an inhaled steroid 2 to 3 times. You want to give them the definitive because you really don't want to give your patient a range because it's confusing. This here is for the therapist to make the determination. So you would tell them, depending upon the severity of the step that you put them in, you would say 2 inhalations twice a day. Or you would say 3 inhalations twice a day. And then you would figure out what the dosage is that you ordered. Make sense?
Yeah.
Okay. So then, how would you educate him on taking the medications? Since this medication is a DPI, what's that stand for?
DPI stands for those. Oh my God, I'm just trying to. I know it has to do with. It's like a
Very good.
powder
Very
inhaler.
good.
Deliver
Yep, that's all you needed.
powder
It's
inhaler.
a powder. It's dry powder inhaler.
Yeah, yeah, dry powder
Yeah,
inhaler.
we in the medical fields love our acronyms, but we can get pretty acronymed overdosed. So the fact that you got it as a powder, I'm happy. So it is a little different than an MDI, because if it's in the powder form, you have to breathe in fast and deep in order to have that powder get down into the lungs, as opposed to the MDI or an aerosolized medicine that's just floating. Then you want it to be the slower breath so that it is a laminar flow and can follow that airway flow down into your lungs.
So the dry powder inhaler is different than the meter dose inhaler. It's a little different than the meter dose
Yes,
inhaler.
ma'am. Yes, ma'am, it is. So she'd also make sure to have him rinse his mouth out at the end so he doesn't get as many side effects and the medication is just delivered locally. Excellent job that she had written there. And If his symptoms worsen over the next week, would you change this plan of action and how? I was very impressed that she was one of the few that recognized that he did not have an asthma action plan. So I developed an action plan for him first so he could adjust medications according to his symptoms and seek medical attention as necessary. If his symptoms worsen, I would switch him over to budesonide formoterol, which would help with his nighttime asthma and improve bronchodilation. Formoterol is a long-acting bronchodilator. So she did a phenomenal job on this.
Are you talking about, so this wasn't yours, this was the students,
This
right?
was the students. It was Valeria's.
Okay.
I just picked someone's.
Okay.
So then going back to the very top of this, remember here it talks about asthma diagnosis, oh, here it is. So on the initial visit, it says assess at each visit, asthma control, proper medication techniques, written asthma action plan. In this case study, it says he has not seen a doctor nor has any asthma action plan that he is aware of. So if you will recall, let's see, modules. I included an asthma action plan. And this would be something that you would go over with the patient. He's doing well. He's in the green zone of his peak flow meter. As long as he's in the green zone, this is the medication that you want him to take. This is how much, so that would be that frequency of 1 time a day or PRN every 4 hours, when to take it, morning, noon, night. Does that make sense?
Yes.
Then yellow zone, asthma's getting worse. Peak flow is 50 to 79% of his best peak flow. If that happens, it's telling you you're going to add quick relief medicine to keep taking your green zone medicine. So this is all additive to this initial one. If your symptoms and peak flow return to green after 1 hour, then continue to monitor to make sure that you're green. If your symptoms and peak flow do not return to green zone after 1 hour of the above treatment, then it's going to have you take your short-acting beta-2 agonist, whichever one you've determined for them, 1 or 2 or 4 puffs or via nebulizer, and then add an oral steroid, which we as RTs do not order the oral steroid, but it's still good for you to understand that this is how this asthma action plan works. Does it make sense with what we were just looking at?
Yes.
And then obviously the red zone, their peak flow is less than 50% of their personal best. It's a medical alert, cannot do usual activities, very short of breath. Quick relief medicines have not helped. It wants them to take particular medicines now and then call your doctor now. So red zone is you're going to get a little bit of information as to what to take immediately, but you need to get care. Make sense?
Yeah.
All right. So, I'm actually going to stop the recording and the official presentation because class time is over.